do land acknowledgement. So I actually looked up what I could find about the history of Mercer Island before white settlers arrived. And I found out just two things. Number one, there were two Snoqualmie tribe villages on the west side of the island that preceded anybody coming here. And the white settlers didn't bother with Mercer Island until 1870. I don't know what happened to those villages, but that's all I know. So I'm camped out on the backyards of two Native American villages.
There are 27 tribes in Washington State that are recognized, and then several more that aren't recognized but have been around here and basically should be recognized. And there's movements.
I'm here in Wenatchee on the land of the Wenatchee or the Piscosa tribe.
And they're still here today. They were here before us and they're still here now. So we need to appreciate that fact. We've got a lot of stuff that they had way back when, and we owe them. Yeah, the first thing I was going to do is just recap the annual meeting, and then we'll finish that recap with the slideshow. So let me, so it was moving mountains for Medicare for all. Preceding the meeting were these lunch bite things and videos going on Monday, Tuesday, Wednesday, Thursday. So for Monday, they focused on how Medicare for all bill becomes law. They are available and I can get them for you. If you registered, you should be able to get the, I know what the link and the password is, so I can get them for you. This one is on privatizations and direct contracting entities, which is really the big stink going on right now. MIG means interest groups, reproductive health, research guild, retired physicians. I think I may have taken that one in. Pediatricians, modern monetary theory, which is, and Thursday were hospital closures and public health. Walter Sue was the medical guy in charge of health department in Philadelphia for a while. And one on rural health, Betty Keller from Vermont. Young physicians, led by Scott Goldberg, who probably just graduated 3 or 4 years ago. Then Friday evening, there was 1.5 hours, I should say. Rachel Madley, who's Pramila's health policy person, was on a panel that we had her as our speaker last month, I think. Saturday, Adam Gaffney showed his slides. Future of Medicare for all physician activism, Saturday. Now, Phil Verhoff is going to be the next president of PNHP. Susan Rogers still has 2022. So at the end of 22, she'll turn over the gavel to Phil Verhoff. Let's see, he's a ICU doc, I think, in Hawaii. Keynote speech talk was done by Dr. Rupa Marya. She's just written a book called
Inflamed.
Inflamed, yeah. So we can go now to slideshow. You can get the slides to use in your own, if you're going to give a talk somewhere, you can pick and choose your slides. But what I'm going to show on this video is Adam Gaffney, past president of PNHP, and been around a long time, kind of narrating the slideshow. So it's a video. Hopefully it'll come through okay on Zoom. So let's see what happens.
But Dr. Gaffney served as the president of the PNHP in 2019, and I followed him in that role. He currently practices pulmonary and critical care medicine at the Cambridge Health Alliance and is an assistant professor of medicine at Harvard Medical School. His research focuses on healthcare financing, reform, equity, and disparities in lung health. His book, To Heal Humankind, The Right to Health in History, was published in 2017. I don't know how he finds the time to do all these things, but he does. He completed his MD at the New York University School of Medicine, did his residency training at Columbia University Medical Center, and was a clinical and research fellowship in pulmonary and critical care medicine at Mass General. I welcome you, Dr. Gaffney, and I'm looking forward to your data update for PNHP. Thank you.
Thank you, Dr. Rogers, for that kind introduction. And I'm really excited to be here this morning. Good morning to everyone who is joining us and who joined yesterday. And yeah, why don't we get started? In typical fashion, I will be showing a fair amount of data. So get ready. I'm going to share my screen right now. Great. And if someone, Susan, could you just confirm that the picture looks good right now?
Yes, it looks fine, Adam.
Great, thank you. All right, so let's get started with the data update for this year. It's obviously been a very eventful year and almost entirely in a bad way. So I want to begin just by looking at the global health trends that we've been seeing both recently and historically. So life expectancy rose fairly rapidly, after sort of 1960s into the 1970s. And the rate of improvement sort of declined in more recent decades and then totally plateaued over the last 10 years with even some years of lost life expectancy. Of course, the final dip you see in this curve is the onset of the COVID-19 pandemic in 2020. And that sudden fall in life expectancy is the result of a surge in mortality. A nearly 16% increase in relative death rate, all cause in the United States in 2020, which is the highest one-year increase that has actually happened since 1960. In fact, going back all the way to 1901. And of course, this is to some extent an act of nature. To some extent, it's also an act of our failure to contend with this, and our policy failures and our political failures. It's not just an act of nature. And we see that because of, in part because we have such a higher COVID-19 death rate compared to other nations, and in part because of the enormously disparate impact that this virus has had. And this is not surprising, but I think it's worth showing briefly before we move over to more medically oriented topics. A 38% increase in all-cause mortality among Hispanic individuals from 2019 to 2020, a 25% increase in Black individuals, effectively a much higher rate of increase among every racial and ethnic group relative to white people. And so what I want to sort of get to next is the fact that this is a giant failure. And it's a giant tragedy, but the groundwork for it has been laid for many years. It can't solely be attributed to bad decisions made by Trump, although there were plenty, or bad decisions made by Biden, and there have been many. First, we have to look back at many years of declining expenditures and support for population-level public health. We focus mostly on medical care, but public health, our public health agencies, the federal, state, and local level are essential when it comes to fighting a pandemic. From 2000 to 2020, the proportion of our total national healthcare expenditures accounted for by public health agencies has declined from 3.2% to 2.6%. But these official statistics, it turns out, are actually an overestimate. These official statistics actually include a lot of spending that's actually more for medical care, not actually for public health, as recent studies have shown. In fact, a recent work has found that those official statistics may overstate our public health expenditures by double. And when you account for this fact, and you look back at per capita public health spending by the states over the last 10 years or so, you actually find there's been an absolute fall in expenditures by states on public health from 2008 to 2018, from $80 per person on public health to $76 per person on public health. And so this has to be thought of as part of the problem. Now, let's shift to medical care for a minute. So from this perspective, we also entered the COVID-19 pandemic ill-prepared. Let's look back over 20 years at what we call treatable mortality. Treatable mortality is defined as deaths that are theoretically preventable by medical care, right? This would not be an overdose per se, but it would be a heart attack, for instance. And so what we see is that the US, in terms of deaths preventable by medical care, the US is an outlier, has the highest treatable mortality of any of these 5 nations I've compared it to. But not only that, again, the picture is of decline and lack of progress in the last 10 years. You can see the blue line, which is the United States, we've had no further improvement in reducing treatable mortality in the last 10 years. And so the gap between us and our peer nations is widening. Other studies have shed light on concerning trends in our in the state of medical care in the United States, and this is, I'm going to talk very shortly about issues involving coverage, access, and equity. But these global trends are important because what we see is that in the last 20 years, with some progress in controlling blood pressure, for instance, among individuals with hypertension, we as a healthcare system have been doing a worse job. Blood pressure control among hypertensives in the United States has declined in the last decade. Glycemic control and blood pressure control among individuals with diabetes in the United States has declined in the past decade. And I think that at least some of this can be reflected, or maybe the result of the inadequacies of our healthcare financing system, of healthcare access. Now, this is a chart that I update each year showing long-term trends in the proportion of the US population that's uninsured. And you can see that, in 1963, around 1/4 of everyone was uninsured. Medicare, implemented in 1966, made a big difference. And things got better through the 1970s as Medicaid was picked up by more and more states. With the onset of the turn towards austerity, Reaganism, the conservative neoliberal era, we saw rising uninsurance, the 1980s through the 1990s. Further worsening into the Great Recession. And yes, a big improvement with passage of the Affordable Care Act in 2014. Yet despite those trends, we see that 10% of the US population remains uninsured. Now let's zoom in on just the last 6 years. I've plotted here the number of uninsured according to the 3 major federal surveys that we use to come up with these statistics. And you can see, according to each of these 3 surveys, there's been a rise in the number of uninsured from 2016 to 2020. Now, we expected a giant surge in uninsurance in 2020, given the pandemic and the recession, and that did not materialize, probably because of some aggressive policy measures that allowed people to retain Medicaid or retain their private insurance plans, and then probably in part because many people who lost their jobs never had coverage to begin with. People who work in, for instance, lower paid service industries, restaurants and the like. But either way, this is that the fact that it was not as bad as we feared does not mean the situation is good. Number of uninsured is rising and is high, around 30 million. Our work recently published looked at sort of trends among children, both in uninsurance and underinsurance. And we too found from 2016 to 2019 a rise in the number of uninsured children, but also a rise, and I'm going to get to underinsurance shortly, in the number of underinsured children. If you combine the 2 numbers, what you see is the number of inadequately insured children in the United States, either underinsured or uninsured, has risen from 22 million in 2016 to 24.4 million in 2019. Again, as with the impact of the COVID-19 pandemic, the impact of our inadequate healthcare financing system is highly inequitable. More than 1 in 4 Hispanic non-elderly adults is uninsured, 15% of Blacks, and relative to 9% of whites. Similarly, 1 in 4 poor, 1 in 4 near poor non-elderly adults is uninsured relative to 9% of those with higher incomes. So this problem is not, unsurprisingly, being experienced similarly by different populations. This is one bit of not new data, but I wanted to put it up there because it drives home the point and why this is an urgent life or death issue. We are not surprised to know that lack of insurance is deadly, but it's being reaffirmed again and again and again by increasingly more rigorous studies with quasi-experimental or even experimental designs. And what these studies show is actually a fairly similar finding, that for, depending on which study you look at, between 200 and, this is a chart basically just summarizing 4 studies and providing the number of individuals you would need to insure to save one life in each of these, according to each of these studies. And whether that number is 278 people you need to insure to save one life, or 830, either way, what this translates to, if you pick a number in the middle, like 500, this means that about, for every 500 people we leave uninsured, about 1 dies each year. And if you say 30 million people uninsured and you divide that by 1 in 500, you're talking about, maybe 60,000 deaths a year from uninsurance in the United States still, despite the gains that have been made from the Affordable Care Act. And so I do think that this drives home, why this is not just an economic issue, it's a life and death issue. Now, as we went into the COVID-19 pandemic, these inadequacies were always going to matter, and they did matter. This is a survey early in the pandemic, but it's telling. It found that about 9% of adults who thought they had COVID said they wouldn't get care because they would be afraid of the costs. All right, and the proportion is higher among non-white individuals and among lower income individuals. So, for instance, 14% of non-white individuals said they would not get care if they believe they had COVID because they would be afraid of costs. Now, these sorts of dynamics undoubtedly played a role in our slow and inadequate vaccine campaign. Because of the underfunding of our public health institutions, the vaccine rollout was very much relegated to private institutions. And what this meant was that there was not an equitable rollout of the vaccine, and there were huge shortcomings. So this is a study, this is an analysis not yet published that we have done, just looking at the early days of the vaccine rollout, January to March, looking at the proportion of people who got COVID-19 vaccinated based on whether they were uninsured or what kind of coverage they had. And what you can see is even when adjusting for age, which is a big confounder here, uninsured people had the lowest rates of being vaccinated, through March. Those who had health coverage did better in orange. And actually, the people who appeared to get vaccinated the quickest were those with VA coverage. And the VA had was an integrated delivery system that had a very targeted, aggressive, and planned rollout of the vaccine campaign, and very proactive. And they sent teams around to deal with vaccine hesitancy. And I think that gives you a sense of what might be possible, not only with better healthcare financing, but with more integrated and intentional healthcare delivery. All right, this is an oldie, but I think a telling slide that I always use, and it's from the satirical publication The Onion, and I apologize if you've seen it before, but I like it. Basically, the gag here is that the company's HR manager are really pushing infinite deductible healthcare plan, and it's the idea that workers being offered this new healthcare plan that is really great because you can use it for any doctor, you can use it for any drug, you can use it at any hospital. The only downside being that you have to pay 100% of the costs out of pocket. Okay, so a kernel of truth here. This is an updated look at the size of deductibles among workers with employer-sponsored coverage. It's been rising. It's gone up about triple since 2006 to 2020. And this is for single coverage. Family deductibles are probably double this, so more like in the $2,600 range. But these are dwarfed by the deductibles on the ACA plans, the marketplace plans, the healthcare.gov plans, Obamacare plans. Now these are the deductibles for those plans for single coverage, and again, family plans are twofold higher. But for a bronze plan for a single individual, you're talking about a $7,000 deductible, $1,500 deductible for a gold plan, and again, double that if you're talking about families. So very bare bones coverage. Now, the reality is that this isn't just a problem financially for people. It's a problem because people don't get the care they need, and it's a problem because it exacerbates disparities in health. A recent study looked at access, insurance by race and ethnicity among people who were just about to get Medicare and people who just got Medicare. And what it found was that before turning 65, rates of being unable to afford going to the doctor were higher, not surprisingly. So, 8.1% of whites were unable to afford to go to the doctor in the last year because of cost, 13.9% of Blacks, 19.5% of Hispanics. After turning 65, not surprisingly, those proportions fell as people gained Medicare eligibility. And not only did they fall, but the racial differences were attenuated, but obviously, as you can see, not eliminated. So we know how to begin to address some of these gaps. But Medicare itself, in its current form, as can be seen, is helpful but not adequate. The longer-term trends here are also very concerning. The proportion of the working age population that is underinsured, defined by high out-of-pocket healthcare costs, has been rising from 12%, up to about a third. About 27%, and the absolute number has risen over the last 20 years from 16 million to 44 million. 41 million. You can look at this kind of, I think when you look at specific patient populations, these numbers become more meaningful. This is a recent study that looked at out-of-pocket costs after hospitalization for trauma. And these are among privately insured patients, okay? And these are just the sort of mean. And I found that, as you get more severe trauma, your out-of-pocket costs went up to $4,000 for insured individuals, privately insured individuals, up to profound trauma. But again, these are means. And there's actually some proportion of individuals who had far more catastrophic costs. As I said, the problem, though, is not just that people get burdened with financial burdens. The problem is that they just don't get care at all. So the proportion of individuals in the United States who go without needed care because of cost is about 35% among working age adults, or 68 million. But the financial impact is a problem. And this is a really, I think, impactful recent study that looked at the total sum of medical debt reported to credit agencies in the United States. And it found that medical debt has been rising and has now surpassed all other non-medical debt considered collectively. So in 2020, Americans held about $140 billion in medical debt, relative to $127 billion in all forms of non-medical debt, like credit cards, okay? Now, keep in mind, if you actually went and you paid for medical care with the credit card, that would actually be counted in the study as non-medical debt. So this may actually be a conservative number. This is seen, again, you can look at specific patient populations to get a sense of how this plays out. This is a recent study that found that 18.8% of privately insured families received a potential surprise medical bill after delivering a baby. And if you look at the specific amounts for these bills, they could be as high as $5,000 for an obstetrical services for a cesarean delivery, or $3,200 for anesthesia for a vaginal delivery. Out-of-pocket spending for maternity care, similarly, all considered among individuals with employer-sponsored coverage, has also gotten very high. A vaginal birth, $4,300 for annual out-of-pocket spending for maternity care, and $5,100 for a cesarean delivery. And keep in mind, this compares to precisely $0 in, say, Canada or the UK. A growing literature is supporting what we sort of already knew, which is that the high deductible healthcare plans are having damaging downstream health impacts. This study, for instance, found that when and this is a sort of quasi-experimental design, people are being inadvertently pushed into high deductible healthcare plans, and sort of what happens to them relative to those who stay in a comprehensive plan, in a good plan. And what happens when people get pushed into a high deductible healthcare plan? Well, they show up less at the emergency room, even with high acuity conditions. In this study, being pushed into a high deductible healthcare plan led to a 4% decline in ED visits for chest pain and 11% decline in ED visits in hospitalizations for chest pain. Yet subsequently, there was actually a rise in acute myocardial infarction, suggesting that the lack of care was actually having downstream negative consequences. Similarly, being pushed into a high deductible healthcare plan, if you're diabetic, translates to a 0.7 month delay in retinopathy screening, a 2.9 month delay in having your severe retinopathy recognized, and a 3.8 month delay in having your vision loss recognized or treated. And again, these are quasi-experimental estimates. This has nothing to do with people's choices. And finally, an important and searing recent study shed some light on the actually deadly effects of cost sharing and underinsurance. So this is a complicated study, and I'll summarize it briefly. Basically, these researchers looked at Medicare in the first year of being in Medicare and getting drug coverage. And there's this sort of quirk in Medicare's design with this donut hole where you pay more in prescription drug coverage as your bills mount up. But because people enter Medicare different months of the year, that sort of accidentally has an impact on your expected end of year drug costs. So forget all that. The point is that there's sort of a natural variation, an experimental variation in seniors' exposure to drug costs in their first year of Medicare coverage. And so economists love this sort of thing because it creates this kind of natural experiment that you can exploit to sort of look at the sort of causal effects of copays, okay? What they found, the first part of what they found is totally unsurprising. We already knew. They found that, as cost sharing copays go up, people don't fill prescriptions. We know that, and doctors know that and knew that. And so like a 1 percentage point increase in coinsurance, the proportion you pay for a drug out of pocket, translates into a 12% decline in statin fills, prescription fills, 19% decline in inhaler fills. Okay, so that we knew. But what they additionally found was that those increases in copays and those reductions in filling prescriptions caused an increase in mortality. In fact, even just this modest median $10 increase in prescription drug cost sharing was associated with a 33% increase in monthly mortality among these individuals with Medicare. So this says something both about the inadequacy of Medicare coverage as it currently is constituted, but far more broadly, it shows the deadly consequences of a healthcare financing system that makes patients pay out of pocket. And this is why PNHP has always strongly advocated for a Medicare for All bill that does not impose cost sharing, does not impose copays or deductibles. There are other forms of underinsurance, though. It's not just cost sharing. There's inadequate forms of coverage. I mean, Medicare beneficiaries, most of them lack dental, vision, and hearing coverage, which is why many were hoping that the reconciliation bill would include expanded access for these forms of care. But it's also worth looking at other forms of denied care, other forms of what we might call underinsurance. And one of the most disturbing ones has been the recent rise in restrictions on reproductive health care access. This is not going to be news, but this study, for instance, looked at the enactment of state laws affecting access to abortion. And they found that from 2017 to 2020, 227 laws have been passed restricting access to abortion. And only 29 laws have been passed expanding access to abortion. This is just a headline from a day or two ago. Obviously, the big law in this respect was what is it, SB 8 in Texas, which effectively bans almost all abortions and sort of deputizes the entire population to basically file lawsuits against anyone who in any way helps a woman obtain an abortion. And so this will come up, so the Supreme Court has not blocked the enactment of that law. And the consequences are already being felt. This is an analysis from the Guttmacher Institute, just looking at sort of the what this means for women in Texas. And so as a result of this, the enactment of this law, the change in the average driving distance one way to an abortion provider rose from about 17 miles to about 247 miles one way. And so for a low-income woman, the time and expense of that kind of travel is probably going to be unaffordable. And so this is effectively denying access to any sort of abortion care for many of these women. Let's reorient for a moment and have a look at another serious problem in our healthcare system, and that is the rising privatization, both of insurance and of delivery of care. And I'll only be able to speak briefly about each of these given time constraints. But the first story I think you may be familiar with, the growing proportion of Medicare is privatized Medicare, so-called Medicare Advantage. The number of seniors in traditional Medicare, passed in 1965, has been basically steady at 38 million. The number of seniors with Medicare Advantage plans has been rapidly rising from 15 million to 23 million. So an increasing proportion of seniors are covered by a privatized Medicare plan. Similarly, a growing proportion of Medicaid is now managed care, run by by managed care organizations. In fact, now at a majority, more than 50% of people with Medicare have a managed care plan. Now, there are consequences of this, and I want to mention a couple of them. We speak a lot about the waste this entails, and I will get to that, but it's also important to be aware that there are health impacts. This was a recent study, and it looked at access to not only receipt of a complex cancer surgery at a top 50 cancer hospital among seniors, and it looked at whether they had, whether that differed, whether senior had traditional Medicare, which has big networks that you can basically go to any hospital you want, or Medicare Advantage, which restricts access to more narrow networks of doctors, more like private insurance, okay? And not surprisingly, they found that seniors with traditional Medicare were far more likely to get a complex cancer surgery at a top 50 cancer hospital relative to seniors with Medicare Advantage. So like a Whipple procedure, 35% of traditional Medicare enrollees had it at a top cancer hospital versus 1 in 5 Medicare Advantage. Now, you don't need to go to a top cancer hospital for everything, but for complex oncologic procedures, there's clear literature associating surgical volume and outcomes. So going to a low volume hospital, which in many cases, that's what this translates to, is likely going to mean worse care in some cases. But disturbing new evidence suggests that the consequences of restrictive access and Medicare Advantage may be even worse than we realized. This is a really complicated study, which I will try to summarize as simply as possible. This study looked at Medicare Advantage plans and the difference in mortality between these plans. Not surprisingly, they found that some plans had higher mortality than others. And you might say, okay, well, some plans will have sicker patients than others. What does that mean about the plans themselves? But what the researchers did is they exploited the fact that some of these Medicare Advantage plans suddenly stop, at the end of the year because the insurer decides they don't like the insurer decides to stop offering them because of regulatory change, okay? And so this creates, again, a sort of experimental situation because you can kind of see what happens when people get kicked off their Medicare Advantage plan and then get a new plan that has different quality attributes and a different average mortality, okay? The long and short of it is they found that, in fact, yes, it's not just that higher mortality plans have sicker patients. The higher mortality Medicare Advantage plans, something about them is actually causing more seniors' deaths. Okay, and again, they're able to make this claim because of that experimental sort of setup that I described. All right, so why is that? What could the Medicare Advantage plans that have higher mortality be doing wrong? And what it seems like they're doing wrong is that these are skimpier plans that provide less care. Okay, so for instance, the medical loss ratio. Medical loss ratio is a metric that looks at the amount of total revenue that an insurer receives that goes towards medical care. So they call it medical loss. We don't really think of it that way. But the long and short of it is, as the medical loss ratio goes up, meaning as insurers pay out more money to care, let more care happen, mortality goes down. Okay, with better prescription drug coverage, mortality goes down. So just to summarize this, the plans, the Medicare Advantage plans that restrict access and that seem to let people get less care have higher mortality. And this really says something about why this model is so fundamentally flawed and why we should move away from Medicare Advantage plans altogether. At the same time, and I don't have time to talk about this too much, but there's been a growing move towards corporatization and privatization of healthcare delivery as well. The number of Medicare beneficiaries who are in private equity or publicly traded corporate hospices has been rising from 12 to 16%. There's also been a rise in private equity ownership in nursing homes. And these are private equity, basically takes over these institutions, tries to squeeze them and sell them for scraps. And the long and short of it is, in the case of nursing homes, the private equity ownership increases the mortality of these patients by 10% and increases costs by 11%. So there seems to be an association between private equity ownership and worse outcomes, not just worse outcomes, higher death. I'm going to close with two final points. One is that when we think about the impact of the COVID-19 pandemic and the ways we were ill-prepared for it, it's important to think not just of access to care, but of where care is and the inequities and the distribution of our healthcare facilities. And this is what the British general practitioner Julian Tudor Hart labeled the inverse care law. It's the idea that the more care is needed, oftentimes the less care there's available. The areas with the most need have the less access. I didn't agree with everything in this New York Times article. The headline, "Why Surviving the Virus Might Come Down to Which Hospital Admits You." And I think the reality is complicated, but it is true that many of the areas that had the greatest need often had the much less facilities and infrastructure to contend with the pandemic. Just to give an obvious example, a recent study from last year found that half of low-income communities, 49% of low-income communities, lacked a single ICU bed, whereas high-income communities, almost all of them had ICU beds. Similarly, hospitals that serve predominantly Black or Hispanic patient populations have much less physical resources measured in dollars, physical infrastructure, capital assets to provide care for patients compared to white-serving hospitals. So I'll close this and then I'll leave us 20 minutes for questions by just saying a few words about the economics of single payer in the current moment. This figure is inaccurate. It shows, and I'll say why, it shows the proportion of total healthcare expenditures that is publicly financed from 1928 to 2020. And you can see the proportion, it is true that the proportion has risen dramatically. What's not true about this diagram is this excludes all of the forms of publicly financed healthcare that is routed through private insurance companies, like the big tax deductions that we get, that private insurance gets if it's provided by employers. And if you incorporate that, the proportion of total healthcare expenditures that is publicly financed is very high, like 2/3. And this is a real problem because routing all these dollars through these private insurers costs an enormous amount of money. The overhead of private insurers and of Medicare Advantage is around 13 to 14%. 13.2% is the latest calculation I could do. And that compares to 2% overhead in traditional Medicare, 2% overhead in Canadian Medicare. And so why is this? It's because private insurers have to pay profits, to take profits, have to pay dividends to shareholders, have to pay their CEOs large amounts of money and other executives, have to design plans, have to market plans. They have all these functions that a public insurer doesn't need to do. We said this for a long time in PNHP. Some of these think tanks that have done single payer economic analysis said, oh no, that's unrealistic. You can't get it down to 2%. And Urban Institute, you may remember these single payer analyses, said no, it would be much higher. Overhead would be 6% under single payer. Well, last year, the Congressional Budget Office, for the first time in 20 years, released an economic analysis of single payer, and they agreed with us. They said, no, actually, overhead under single payer would be 1.6%. That was the CBO's estimate late last year. We spent a lot of time thinking about administrative overhead and the waste that it entails. The reality is that it's not just about economic waste, it's about human cost. Again, another satirical headline from The Onion, and it's dark humor, but I think it rings true. Man dying from cancer spends last good day on phone with insurance company. This is a study published just this year that found that U.S. workers spend 500 million hours a year on the phone with health insurers. This is all workers, obviously, not just one. And about half of that is at work, half of that's at home. And those kinds of administrative burdens lead to foregone or delayed care due to administrative burdens among 1 in 4 non-elderly adults. This is in addition to care foregone for cost-related reasons. So I'm going to end here and say that, amidst all that, we did have the CBO report last year, and in many ways it had some unfavorable assumptions, but in many ways it really reinforced just how doable and economically feasible single payer is. They found that no matter how you design this single payer, they found that national health expenditures would fall or maybe rise slightly if you had the most generous system, not just in terms of coverage, but in terms of how much money you gave doctors and hospitals. In fact, under their generous estimates, doctors would actually have a windfall, which I don't think is needed for most of us. And they basically say that the savings you get from getting out the fat of the insurance industry would be basically enough to cover the costs of increased care. They estimate $400 billion a year in reduced insurance overhead by 2030. And that's not even accounting for savings on the provider side in terms of reducing those armies of billers and coders at hospitals' billing offices. So I'm going to end there and take some questions. And thank you all again for listening in.
That was really interesting, though sad.
Well, the slides themselves are available in a PowerPoint file. So if anybody wants them, they can be available. Put them on the PNHPWA website for download.
I scribbled down a couple of notes and comments as it went along. My first one was that showed no real evidence that there was any improvement in mortality avoidance by treatment. What did they call that? Treatable illnesses. The Affordable Care Act came into being, insurance rates went down, but the mortality rates stayed the same. I thought that was interesting because the ACA, while it gave more people insurance, it didn't do anything about out-of-pocket costs that inhibit people from getting treatment for things that they don't have to die from. So it again points to the need to get rid of out-of-pocket costs because they inhibit the seeking of necessary care. the theory that we're avoiding seeking unnecessary care doesn't pan out in the experience of other parts of the world that don't have any significant out-of-pocket costs.
Well, these Medicare Advantage flyers you get in the mail and stuff you see on TV all over the place, they kind of say, well, there's no out-of-pocket costs and, you know, you get free this and that. But then that goes, these slides go in contradictions to that. So I think basically most people don't use their insurance. What, 20%? Only 20% of people per year use their insurance. So those 80% that are buying Medicare Advantage plans, you know, they don't have to pay anything because they don't use it.
They're discouraged from using it too. There's no, you know, they're, you know, you come in for your whatever problem and nobody tells you that you really should get regular checkups on your diabetes. So if you feel fine, you may not go see the doctor for another year or so.
Well, what they do is that when you sign up for you turn 65 and you sign up for one of these Medicare Advantages, and they invite you in for your welcome to Medicare well person visit, and they use that visit to up risk, to give you more risk things like pre-diabetes or something like that. So they do all that. And the other thing they do sometimes is send a nice nurse out to your house to see you at home, which seems like, oh, what wonderful service to have this nurse come out and check me out at home. But what the nurse does is look around for more things to raise your risk factor, so that that brings in more money in the capitation from Medicare to the Medicare Advantage plan. So that's a big scam, and it's recognized, and they're trying to avoid it, but they haven't really. The Medicare folks are not able to keep up with the scheming that the insurance companies are capable of doing. So that all goes on. And, you know, I have a good friend who is retired now and was a family practice doc and really should know better. And she has signed up for a Medicare Advantage plan. And I don't know all the details, but she says it allows her to pick whatever specialist she wants, or so it says. And of course, she's relatively young and nothing big has happened to her. But she did talk about how nice it was to have this Medicare checkup and all of that.
Those plans are, or many of them are advertised as no deductibles, but they get you on co-pays and co-insurance and lots of other things that you find out, you know, later when you get your bill.
Yeah. The next thing that I noticed brought to mind Costa Rica. There was a big article somewhere on Costa Rica within the last year or so about how they have merged their public health system with their general health system so that they can, for instance, send a public health nurse out to somebody's home to check on what's going on because they didn't fill the medication they were supposed to get. And so to go and check on people. So they had this integrated way of doing it. And it was on the, you know, small town level. It was something that would really work in a country like Costa Rica, where there are relatively few large cities and more smaller communities. I have difficulty seeing how something like that would work in, say, Seattle or the Seattle area where people are scattered all over. But I thought it was intriguing that merging public health with the other aspects of the health system allowed for much more ability to follow up on people who are falling through the cracks. So I would love to see some kind of an experiment like that done here. Yeah.
The Medicare Advantage plans, they don't want to seek anybody to come and be seen. So they're not interested in having another office visit.
Right, but they also don't follow up on somebody who doesn't fill their medication, say.
Oh,
Or
for
who
sure.
doesn't keep an appointment, or
Right.
doesn't make a follow-up appointment.
Well, they love it if they don't make a follow-up appointment.
Right, so they're thinking only of the immediate money that's not spent and not of the potential downstream higher cost because the person it gets sicker because they're not following through. So we have a system that doesn't focus on what's happening with the patient. It only focuses on how much are we spending and how do we spend less.
And you know, there's always the hope that once the patient gets really sick, they switch plans. And so that particular plan doesn't have to incur those other additional costs, because like maybe that person isn't going to stick around with that plan. They might go to a different plan. They might go to Medicaid. They might, you know, they
Well,
might.
Also, the Medicare Advantage plans might say, well, we're losing a whole lot of money in this particular area, so we're going to stop the plan and we're going to, you know, go somewhere else. Or, you know, we've got several plans going on in different places that are profitable, so we'll just forget this one. They did that, you know, in Houston, where they, you know, thousands of people suddenly lost their doctors who, because the Medicare Advantage plan didn't want people to go to the cancer centers there. And Houston is a big area for cancer centers. So what was it, 20, 30,000 people suddenly found that they had lost their doctors and their, you know, hospitals that they went to for their cancer treatments.
Well, they just pulled that.
I was at Fred Meyer's and now it's called Kroger Health. And they had two reps there, insurance dealers. And, you know, he told me that Kidderminster County only has one Medicare Advantage plan now. But if I lived in King County or Thurston County, it would be no cost. He kept saying no cost. He kept throwing that out. No cost, no cost. But if I got the only plan available in Kidderminster County, it would be $100 more than the standard Medicare Premium. But he said, you go to King County and you can get the same plan for no cost. So I challenged him. I said, I'm going to go and pretend I live in King County and see if I can get it for no cost. I haven't done it yet. It's just 2 days ago. But
You'd be a
you
secret shopper.
Yeah. It's anyway, you know, he personally suffered at the ACA, the cost to his family, you know, but I think you guys all know that Elaine Chow is now on the board at Kroger's. When I go to my Fred Meyer's.
Oh dear.
Yeah, I don't think Mitch McConnell would move on the infrastructure bill till Elaine got on the board. And so now this is the Kroger Health. They got the United Healthcare, these guys selling Medicare Advantage in the lobby of my Fred Meyer's. It's just the way it is. But it's almost over, you know. I had a nice long talk with the clerk at AAA in Bellevue today, and she was listening and listening and listening. And she said, thank you, you know, for introducing her to House Resolution 1976. So it's almost over.
What one is that?
Oh, that House bill.
Medicare for all.
That's the Medicare for All bill, Jayapal bill is HR 1976.
Oh, okay. Sorry, didn't catch that.
Yeah.
It's a catchy number.
Yeah.
Well,
Right. Well, the other thing that was in today's paper is that they're planning to raise Medicare premium that we all pay. Part B premium is going up. It used to be that $100 was sort of what it wouldn't be. And they broke that barrier quite a while ago. And now it's going to go up apparently to $170 a month.
14.5%. And I saw a headline that said because they can't predict the cost of the new Alzheimer drug.
Right, it's
I'm-
that
I'm-
$56,000 a year costs from the pharmaceutical company for
It's
this
another,
Alzheimer's drug that may or may not do much.
it's a blank check. I'm researching Ralph Nader Radio Hour because he had those FDA whistleblowers, the people who quit because of the approval process on that drug. Because I want to send it to, I want to call the lawmakers, tell them to listen to these whistleblowers. you know. Anyway, anybody watching Dope Sick?
Well, the next comment that I wrote down is that excuse me, when Medicare was started in 1965, 20% coinsurance didn't seem like a big deal, but it has become an awful barrier. And people tend to forget that coinsurance. All of us probably have a Medigap policy that covers that coinsurance. But for people who just have Medicare, that coinsurance is huge. That means if you get some kind of cancer treatment or surgery, you're paying 20% of it. Even after Medicare cuts down the charge master to a more reasonable charge, you're still paying 20% of it. And we tend not to, all the talk about what's in the Build Better and all of that are focusing on vision, dental, and hearing. But the thing that really hurts is that 20% coinsurance. And that hits you just for going to the doctor. Anyway,
Okay.
we need to really keep the focus on all four of dental, vision, hearing, and get rid of that coinsurance.
So I think we're going to talk some more about this stuff as we move down the program here. But so
Okay,
basically that's the recap of the annual meeting and the new slides. So since I'm a board advisor, there's a board advisor and a board member of PNHP national meeting once a month. So this is just some stuff that was talked about at the most recent board advisor meeting a couple of weeks ago. So PNHP has a new president-elect, that's Phil Verhoef. I mentioned it before earlier this evening. So he's an ICU doc at Kaiser, Hawaii. He'll take over at the end of 2022 when Susan Rogers finishes her term. There are regional meetings, 4 different regions in the United States that the national office is trying to get chapters in those states to meet together however often they want to do. And we had a first meeting of the West regional meeting a few weeks ago. In the West region is Washington, Oregon, California, Alaska, and Hawaii. So the idea there is to try to coordinate efforts, see what people are doing on the West Coast, and help each other out if we can, or trade ideas. So that first meeting was just sort of a get to know you meeting, and there'll be another one coming up. So the National is pushing 3 campaigns and setting up 3 campaign teams amongst members of the board, national board. So there's those who are focused on pushing national single payer legislation, those that are working on the DCEs and privatization of Medicare. You know, DCEs, this is a huge stealth attempt to privatize Medicare that's been going on. And I think there's like 5 or 6 regions or something where the Medicare is turned over to private equity firms. And, you know, of course, they're supposed to be able to do it better and cheaper, but that's baloney because they're private equity and there's profit to be made. But anyway, if you're in Medicare, you may suddenly find out you're in one of these DCEs. So I think there's legislation to roll these out in 5 different areas in the country to kind of see how it works. But I think it, you know, was introduced under Trump, and it's basically with in the, you know, the MSS or whatever it is, the government entity that controls Medicare and Medicaid. So they've got this program out there, but they haven't implemented it yet because they're getting such huge pushback from people who are seeing what's trying to be accomplished there. So I think.
Oh, what does that stand for, the initials?
Well, I think it's a Medicare Center for Innovations that's in the Affordable Care Act. And the Trump folks took advantage of that to start this innovative idea of privatizing Medicare out in other ways than Medicare Advantage. And
Right.
it included the possibility of automatically assigning people without their consent on a basis of geography. But that part has been put on hold. But they do have several areas where they've got some DCEs going. I don't know, and I think there's some in every state, including ours.
Do you know what the initials refer to, DCE?
Yes, direct contracting entity.
Okay.
So one of the things that concerns me is like the polyclinic. They've been pestering me to sign up for their Medicare Advantage, but I wonder if they won't also get involved in some kind of direct contracting thing that will assign me in some way.
Well, they have been bought out by United Healthcare, so it's no longer polyclinic independent.
Oh, really? I didn't know that.
Yes.
Yeah, United Healthcare has some DCEs planned. So basically it's a stealth privatization that, you know, you can get assigned. I think they were trying to assign the whole city employees of New York City to one when the word got out about that. They had tried to make some deal with the unions to allow the unions to be into it first, but that's on hold. And I think Healthcare for All Washington at their annual meeting had a talk by Steve Kemble,
Mhm.
who's on the PNHP National Board and,
Yep.
you know, from Hawaii, and he's an expert on this DCE privatization thing. So I looked at the website, Healthcare for All, and it didn't seem like the meeting is up on the web yet, the video of it, but I think there's a plan to do that, isn't there, Sherry?
Yes, that is my understanding that they do plan to do that. The annual meeting was just this last Saturday, so I don't know how long it takes them to get that done.
And there's a PNHP board member, Anna Malinoff,
Malino, yeah.
who put together a video on DCEs that, you know, so what, 45, half an hour, 45 minutes long, but we definitely need to be concerned with that. And, you know, if they try to implement it in our area, we've got to work with Healthcare for All Washington and Healthcare as a Human Right Washington to stop that. So anyway, that's a campaign team from the national. And then Medical Society Resolutions is another of the 3 campaign teams. I think
I think you all know that I got one through the WSMA at its last annual meeting.
Wow.
I basically filed the resolution straight off of the PNHP website. And of course, they didn't try to change all the whereases at all. But they did manage to insert by multiple means, including, instead of just by single payer or by a, I didn't use the word single payer because that's such a red flag for a medical society, but I used publicly funded. So they said by multiple means, including publicly funded, so that it enables, the good news is it enables the Washington State Medical Association to support the Universal Healthcare Commission if and when they come up with some kind of a plan. And the people who are on that commission are, they have a large number of people who are dedicated single payer supporters.
so in that
for you.
resolution, it doesn't say publicly administered, right? Just says
Publicly funded,
but
that's
not
right.
So there's an opening there for private insurance to administer it.
Well, I suppose, although contracting out claims processing to an insurer who's got all that and the workers trained to do it is not a bad idea. You just don't give them any capitation or any incentive, any ability to deny claims. They just process them.
They can't have any risk-bearing implications.
Right. And that's one thing that Dr. Kemble really emphasized, is that the risk needs to stay with the public, with the government, which covers all of us. And if they have the risk, then we are all in the risk pool. And so you
Correct.
don't have profiteering going on. But as soon as you start to let people take on risk, like say Kaiser says, oh, that's fine, just give us capitation. Then Kaiser is now bearing risk and decides what to do. And Kaiser is no longer the good guy that it was when it started in California umpteen years ago, more than umpteen, close to 100 years ago.
So anyway, we'll get to that later, I think, in our plans. Also, there's going to be, right now, there's one national organizer out of the Chicago PNHP office. So they're going to have a second national organizer, I think, hired in January, February. And this person's duty will be to support the SNAP chapters and also support our chapter activities. So
SNAP.
Students for a National Health Program.
So, and I've been communicating with the national organizer, Caitlin, and she's been very helpful. And I think a second one would be even more helpful to our chapter and our activities. And I'll get to that a little later here. So let's see. So the board, national board is gonna, understands that we need to cooperate with other single payer groups more than we have in the past that are working for a national Medicare for all, and form some kind of a working group that communicates on a regular basis, like Public Citizen and things like that. They have worked together, but work together more closely, and maybe National Nurses United. And the PNH board will meet monthly. And past years they met on a much less regular basis. Maybe even twice a year or once a year anyway. But twice a year was, but now it's going to. In the past 6 months, it's been every month. And there's
I
also,
think that that's a positive result of COVID and Zoom, that Zoom has really come into everybody's lives and makes these meetings much better, that you're not going to have everybody travel to Chicago every month, or even just being on a phone call. There's nothing better than having these Zoom capabilities.
Let's see. Also, there is a monthly activist call, which it happens to be tomorrow night.
Yeah,
So that's worth tuning into also. Usually there's about 60 people or so across the country that aren't on the board or board advisors, although many of them are, but it's definitely, kind of a low-key meeting. You can get to know other people from around the country and what they're doing. So I would highly recommend people tune into that. It's tomorrow.
I'm planning on it tomorrow. I think one of the things they're planning to emphasize is the progress of the resolutions system. So I sent a whole thing about it to Caitlin. So I'm going to be on it tomorrow. The Medical Society resolutions.
Do other people on this call tonight get the email blasts about the activist meetings? In the link? No?
Oh, I
I
didn't
don't-
get it.
Not sure. I've been getting like hundreds of emails every day.
How right you are. I did 110 junk emails before signing on to this today.
All right, so last part here. PNHP Washington plans for the near future. Basically, we're going to implement a lapsed members campaign team where we reach out to people who have paid amounts of money and been members of PNHP in the past. And we got a list from national of 100 such folks who have paid dues within the last 4 years, I think it is, and have recently lapsed or may lapse in the next month. So we're going to have a local team as well as other chapters across the country to try to reach out to these members. And we got phone scripts, email scripts, and plan from the national office to how to go about this campaign. So we're going to talk about that at our PNHPWA board meeting on Sunday,
Right.
coming Sunday. And we've got a couple of volunteers for that campaign already, 3 volunteers, I guess, and maybe 4. Also, the National is offering to help us improve our social media efforts, and then we can plan a teaching session there where they tell us how we can beef it up, and they can help us because, we have a PNHP Facebook page, but basically nothing is ever posted to it. But I think we need to develop that because a lot of nonprofits use Facebook for helping spread the word, and we should be doing that, and it wouldn't be that hard. So we can talk about that, setting up a meeting, and the national has one of the staff members is dedicated to doing social media stuff, so they can give us a teach-in about that. Then the resolutions campaign, I think Sherry mentioned that, and fighting DCE and privatization emphasis, and we want to be on the lookout for that. And lots of organizations around the country are really tuned in on that, the DCEs. So, anything that government or Biden's not DSHS, what is it? DMS?
It's CMMS, and it's a piece of that.
HHS, is that it?
No, CMS, Centers for Medicare and Medicaid Services.
Okay.
And under that is the some sort of a innovation thing that they're allowed to do.
Yeah, there was just a Washington Academy of Family Physicians CME for 4 hours last Saturday. And the first topic was about how to manage all this stuff. DCE, MIPS, and various other, like, optimizing how you relate to these new payment opportunities or whatever. The rest of it was actually medical information. But the first part out of 4 or 5 sections was about this money stuff and all these different potential ways of making ends meet, I guess.
Well, do they see it as a danger or an opportunity?
They were not making any value judgment. They were just saying, this is how you have to approach it. This is what you have to, how you have to apply and do this and that. And it was kind of like, I was not really listening too much. It was pretty obscure information. But, you know, if you were in the midst of a situation in a solo practice or a small group, you know, you have to pay attention to that. Otherwise, you'd be losing money because, you know, whatever, they would penalize you.
Okay, well, there's the Build Back Better, which they say they're going to vote on that this week, right, in the House and before
Say
Christmas.
so.
But
Yeah.
yeah, I mean, and now it's already Wednesday night and they still haven't done it. So,
I think the whole idea of the centrist Democrats was to, you know,
I don't know why they call them centrist. They seem to me to be rightist.
corporate Democrats is good enough.
Yeah. That's good, yeah.
But they got people like Pramila to agree to vote on the infrastructure bill,
Yeah,
saying, okay, we'll do that first and then.
right.
I think the unfortunate thing is that if we don't let Biden get some victories, which side of Trump would you like to see in 2025? So it's you know, control over the legislature, over the Congress can ride on all of this. So we've got to,
Yep.
we've got to stop squabbling among ourselves and start compromising in order to get something done. And remember that we really don't have control of the Senate, even though in theory we do.
Well, we got to keep fighting for the expansion of Medicare into dental, hearing, and vision. I mean,
That's
Yes.
true, but not to the point of refusing to vote for this plan if it comes down to it.
well, I don't know, because the overwhelming majority of the American public is in favor of it. What's in the Build Back Better? It's just corporate Democrats like Manchin and his ties to coal and, you know, cinnamon, insurance and so on that are holding things up.
That's true.
But supposedly Biden told Pramila that he's going to guarantee that votes in the Senate. So that got Pramila to say, okay, we'll vote for the.
Well, right. But is it really going to happen? Because it's
Okay.
Wednesday night now.
No, it said next week.
No, this week. This is the week.
I think they said by Friday.
Yeah, that's the latest, but
Could be Saturday, could be Sunday night. The
Mhm.
way things go there.
so these are much more exciting times than they were a year or two ago about the possibility of moving forward on some of this stuff. So, you know, we've got to lend our effort to lots of different organizations that are working on this. You know, Washington Community Action Network is mobilizing its people, healthcare, Human Rights Washington mobilizing its people for Build Back Better and the voting rights bills and all that stuff that's kind of stuck by the corporate Democrats. And so the last point here, so PNHPWA wants to continue working with other local single payer organizations that we have really in the past couple of years, but tighten up those.
What happened to that local, state resolution or initiative that was supposed to be for single payer for Washington state only? Was that on the ballot?
No, you want to talk about that, Sherry, about the new commission, the Universal Health Care?
Well, I'm not quite sure what you're talking about. There are two things.
No, I'm talking
One
about
was whole Washington was
Yeah,
trying to
that-
run an initiative campaign.
that one. Yeah, that's the one I was asking about. Is that like still ongoing or is that like done?
I think they're out trying to get signatures again. And if they get enough, it will be submitted in the 2022 legislature. It's an
Oh.
initiative to the legislature.
I see.
So the technical aspects of it are that they have through the end of December to gather whatever number of signatures they have to have. If they get enough, it goes to the legislature, and the legislature can do one of three things. Number one, they can say, oh, that's a good idea, and they can pass it into law. Number two, they can say, this is a terrible idea. We aren't even going to touch it, in which case it then goes on the ballot in November of 2022. And the third thing they can do is say, we're going to do something different and modify this, in which case both the legislature's modification and the initiative go on the ballot in 2020. That third choice, I don't think has ever been selected in the history of Washington's initiatives. It's all either, yes, we'll pass it, or the hell with it, it goes on the ballot.
Oh, okay.
Okay, so that's that, but there's another factor in this, and that is the people running the whole Washington initiative have been sufficiently irritating to the legislators that the legislators are not going to give them the time of day.
Mm.
They have just alienated all the any progressives or mildly progressives that might be there. Is just causing them to roll their eyes and say, oh my God.
Really? Why?
Yeah.
How? I mean, was it substantive or just like annoying people or something?
Annoying people.
Mm. That's terrible.
It is. It's too bad because, as you know, with Healthcare for All Washington, we wrote the Washington Health Security Trust and tried to run it as an initiative in 2000. That was 21 years ago.
Wow.
That law, we've tinkered with it a little bit, and I just recently went through the whole thing and shined it up a little bit, because our plan is to present it to the Universal Healthcare Commission at an appropriate time. But Healthcare for All Washington has got a good reputation with the legislators because we have worked with them on some of their bills and the like, so that they respect us as people who know our stuff and who are willing to talk, not just shove over.
So
Which-
Sherry, talk about the Universal Healthcare Commission.
All right, now the
sounds good.
Universal Healthcare Commission. Remember, there was a Universal Healthcare Work Group a couple of years ago that passed in the 2019 legislative session. I was a member of it, and it met several times in late 2019 and through 2020 with a lot of difficulties thanks to COVID and eventually moving on to Zoom. And it did write a report that said that the best option would be to have the state government run a universal plan financed through taxes, and and do it directly, no insurance involved at all, and that would save $2.5 billion a year in our state, assuming we could get the federal funding coming in. It could save a lot of money, and that option B was for the state to run the program, but to farm it out to various insurers like Healthy Options. And that would cut the savings almost to zero, to like $500,000 a year, maybe. And then the third option was to tinker around the edges of the ACA to try to improve the ACA. And that was not selected at all. The Universal Healthcare Work Group voted to that they favored option A, which is the state running the program using taxes of some sort to do it, plus all the federal, but to consolidate it all in the state government, and the state runs the program directly. Just like some of us are old enough to remember when we billed DSHS directly for Medicaid patients. As a pediatrician, I definitely remember that. All right, so the first recommendation from that to get it going was to set up a Universal Healthcare Commission charged with developing the program to hand to the state legislature to pass. And then the state would be in charge of running it. So legislators put a bill in 2021 to set up a Universal Healthcare Commission, and that passed. And it does not have a direct charge to come up with the plan, but it at least is, but it also has been set up permanently. It's not just given a couple of years like that Blue Ribbon Commission to get the job done and write a bunch of recommendations, but it's supposed to deliver a report by November 1st of next year on the outlining the state's readiness for a plan like this. And that would include looking at how do we get the federal funds, which is difficult. So anyway, that's what they're supposed to do. And of course, COVID caused a lot of problems. So the governor took forever to get around to appointing the members of the commission. And that just happened within the last week or so that they have appointed. And meanwhile, Healthcare for All Washington proposed 12 different people for this commission, from people from all over the state, people of all sorts of descriptions of racial backgrounds and sexuality and whatnot. And this was for 6 spots for the governor to appoint. 5 of our 12 were selected. All are single payer supporters.
And that includes the head of it.
And yeah, the governor was also responsible to name a chair for the commission, and he chose one of our 5 as the chair. It's Vicki Lowe, who represents Native American tribes and is active in tribal healthcare systems. So she knows whereof she speaks, and she was on the work group. Another member is a Somali, I think he's Somali,
Yeah.
Immigrant from the South King County area, and he was also on the work group, and he has been appointed, Mohammed Shidane, and he's active with a community clinic in the South King County area. And then there's somebody from the Farm Workers Clinic that we recruited, the Farm Workers Clinic in the Yakima area. And
Vicki Gomez from
Nicole Gomez, who is, I've forgotten what she is that she actually does, but she is very active with the Healthcare as a Human Right Coalition.
No, I think it's the Washington, the one that Bevan McLeod started.
Right, that's right. Bevan McLeod started some sort of a alliance for Washington Healthcare or something like that.
Yeah, but anyway, I was very impressed by the people who got appointed. And I think 2 are appointed by the Republican caucus in the House and Senate and 2.
Right, so we talked about 6. There are 4 that are legislators, one from each party from each house. And the 2 Democrats are strong.
Right.
They are Emily Randall, who was the chief sponsor of the bill that set up the commission. And I've forgotten who it is now. I'm blocking on it. I should know.
Is it Nicole Macri or?
I don't think it was Nicole Macri. But it's a strong Democrat. And it's Riccelli. And that's important because although he hasn't been on the front lines of activity, he is very much involved, and he is from Spokane. So that's getting somebody from Eastern Washington in there. The 2 Republicans, one of them, Ann Rivers, has just resigned for some reason. So resigned from the legislature. So she's a senator, and I said, who knows who they're going to do. And the other one is Joe Schmick, who is a Republican representative from Eastern Washington, who was on the work group. I actually talked to him a little bit while he was on the work group, and he is a little more, there's a crack of openness in him. We'll put it that way.
But I was surprised that, I was skeptical when, before seeing who was named. And now I think there's some hope in this thing actually moving us forward.
That's right.
First meeting is supposed to be in the next couple of weeks, isn't it? And it's an open meeting that you can watch, right?
Well, what it is, I don't believe it's been publicly announced, but we have our spies on the work group who have said that they're meeting November 30th. So that's a Tuesday. We'll see.
I think you can sign up online to get notices from it.
You can, and I haven't gotten a notice yet.
No,
So
I did too, but I think we all should.
Now, I was wondering if this is supposed to be having some action November of next year.
they have to write a report by then, but it's not proposing a plan. It's just laying out the state's readiness to move further.
But it will need federal approval.
The plan, their report doesn't need federal approval, but we get a tremendous amount of money from the feds to pay for healthcare in the state of Washington. Consider all the Medicare money, the Medicaid matching money, the veterans money, the Indian Health Service money, federal employees' health benefits. All of that federal money, and speaking as one who is insured through the federal employees' health benefits, $1,000 a month goes from the federal treasury to Blue Cross Blue Shield as the federal employer's portion of our Medigap policy through Blue Cross Blue Shield. That's a special one for federal employees.
Per person, $1,000 a month per person.
No, it's $1,000 a month for the 2 of us.
Well, whatever, but it's yeah.
Because my husband is the employee.
So I'm just wondering about November is another election when we might not be so blessed as we are now, federally speaking. So is that going to have some sort of impact on whether this plan could even be materialized?
That's right. And that's the reason why it's really important. The state-based universal health care bill that's got a number like 2773 or something like that, that's in the, it's filed in the House by Ro Khanna. in the national, in Congress. And nobody's paying much attention to it, but they need to. That is
Well,
very important.
What is it? What does it do?
It makes it easy for, if a state has a plan for a universal coverage, it allows the CMS to say, looks like a good plan, and then to bundle the federal money and send it to the state plan.
Oh, wow.
I thought
As I always say,
the,
excuse me, David, is that San Francisco's already achieved that in the courts anyway, with their universal health care plan called Healthy San Francisco. And but I also wanted to answer something to Mindy there, that how the whole Washington event summed up, or how it went,
Yeah.
was they suspended their initiative due to the COVID, actually, because it was too difficult.
Oh.
It proved too difficult.
Right,
their
but they've
signature.
just recently been soliciting, because I get their stuff.
Oh.
And they're planning on starting up again. And either they are planning it or they have started up again with gathering signatures.
Oh.
But I'm just saying too that people were very receptive to it. When I was gathering signatures, I was having very few refusals.
Yeah.
Well,
it's
people,
good.
if you don't, I mean, it sounds good,
It's not a bad plan. And part of the reason it's not a bad plan is that I actually worked with Whole Washington when they were drafting the plan. And I said, don't start from scratch. Use the Washington Health Security Trust Bill.
Ah,
And
great.
so the whole Washington bill, is built much like the Washington Health Security Trust Bill. The difference is they went on to add a whole complicated financing scheme to set up taxes and all. They did that. Whereas the Washington Health Security Trust Bill originally had a financing scheme, but because the legislators were always picking at that and not looking at the rest of the bill, but just, oh my God, how are we going to, payroll tax, premium for individuals, et cetera. So we took it out and instead put in that joint select committee of the legislature that's responsible for the ACA exchange, that they would be responsible for devising the financing for the bill. If the waste were passed, it would be turning the job of figuring out the financing over to that committee. The whole Washington people didn't want to do that. They wanted to include financing. And so they built they got an actuarial study from Gerald Friedman at the University of Massachusetts, or the University of Massachusetts in Amherst. And they built a whole structure for that is more than half of the language of the whole bill. It's quite something to wade through. It would work, but you still have to get the federal money.
right. Although they claimed that there's a way to work around that.
Whole Washington does?
Yeah. In the financing plan of Friedman, it doesn't necessarily have to get federal money into it.
But then again, Healthy San Francisco has gone through the courts and said that they have to secure that, and that money has to go forward to them. So you got precedent to a limited extent.
Hard to know how that would work, but the federal government pays somewhere in the neighborhood close to half of the total amount. And so raising twice as much money in the state to run it would sink the whole thing because it would be too expensive.
So we're at the 2-hour mark.
Oh my gosh.
Hmm,
Time
okay.
flies when you're having fun.
So
It's-
by tomorrow morning, I'll try to send out the link to that activist meeting tomorrow night. I think it's 6 o'clock or something like that. It's worth
Oh,
I believe it is 6 o'clock because it's
Mm.
nationwide. So it's 9 o'clock East Coast time and 6 o'clock our time. And I guess 4 o'clock in Hawaii.
7 o'clock here.
Oh, right. I keep forgetting that you're down there in sunny Arizona.
Yeah. Yeah. Well, very informative meeting.
Thank you.
Good. All right, anybody want to sign off?
I just had one more thing to say on the initiatives is that there were so many people who had something to weigh in on the past election. You know, some people didn't like the guy who was at the top or something like that. That one reason this initiative didn't pass was because it's based upon the percentage of collected signatures you have to collect was vastly higher than the previous years when they tried to run that same whole Washington program. But I think that was Trump that people were interested in voting out anyway. But that condition, how many registered, how many voters they had to have to qualify it for being put on the ballot.
I think we had the highest turnout we've ever had in our state or something close. So yes, this raised the number of signatures they're going to have to get.
Mhm.
But I think a better approach is to bring either the WISD or the whole Washington bill or both to the Universal Healthcare Commission when they're ready to look at, oh, okay, what could we do? These are both things that we could do. They're slightly different, and especially regarding financing.
All
Well,
right.
that sounds optimistic.
Well, I hope.
Well, also see if I can find, do you have that link to where you can get emails from the commission to tell you when they're meeting and how to attend?
Boy,
know-
I don't know how.
It popped up when I went on the website and now I can't find, and I X'd it out and now I can't find it again. But
Well, I
interesting,
just went looking for it, looking for the commission. When you get into the way I got there before was through the governor's website
yeah.
and the commissions that the governor is involved with. And you can follow that link, that trail, and it'll lead you there.
Seemed to me, Healthcare for All Washington, that's where I got the link somehow.
The other thing, the way that I got it is because I was on the work group, I was already linked in to following what was going on the work group. And they're discontinuing that. And so they said, but do you want to sign up for the Universal Healthcare Commission? So I switched it. So I would go in and just start exploring on the, either try with the governor's website or just Washington State Legislature or Washington State government, which is how I found this 2007 report.
Well, we'll get it to you long before they have their first meeting, I'm sure.
Well,
Okay, good
November
night.
30th
I'm
is
gonna
not that
take
far
sign
away.
off.
Good night.
I have to sign off now. Good night.
Okay, stay
Thank you.
warm.
Yeah.
Yeah.
Stay dry. That's a little harder up here.
Good night. Yeah, good night.
Let's go for a healthy King County.
Yeah, and don't forget, we have a board meeting coming up.
2, 1.